All right. Well, good evening, everyone. I was just checking my time, making sure that it is evening. It is. My name is Heidi White, and I am the Wellness Manager at JCC Greater Boston. Special thanks to Beth Israel Deaconess Needham and Beth Israel Deaconess Medical Center for their partnership and for helping to coordinate our Wellness Speaker Series, including tonight's presentation in honor of Mental Health Awareness Month, Brains, Bots, Belonging. What AI and digital tools mean for mental health with Dr. Kalinich. Dr. Kalinich is a physician, scientist, and entrepreneur working at the intersection of psychiatry, data science, and translational medicine. As the Associate Director of the Digital Psychiatry Division at Beth Israel, he works on how to safely deploy generative artificial intelligence to improve how we detect, monitor, and treat mental illness. He received his MD and Ph.D. from the Harvard MIT combined MD PhD program and previously co-funded Watershed Bio, a multiomics platform for accelerating drug discovery. Just a few housekeeping items about tonight's format. This is a webinar style format, so we can't see, we can't hear you. We'll be using the Q&A feature located at the bottom of your screen, and you'll be able to type your questions throughout the talk. I'll be monitoring the Q&A, and Dr. Kalinich will answer your questions throughout the talk, and we'll save some time at the end of the presentation. And so with that, I'm going to turn things over to Dr. Kalinich.
Well, thank you so much for the lovely introduction, and thank you to JCC for the invitation to talk about a topic that's been seeming more and more timely every day, the growing use of large language models in healthcare. So today I want to walk through what AI has been doing in mental health right now, both the genuine promise and the very real harms, as well as discuss a framework for thinking about it. Briefly, in terms of disclosures, I used AI tools extensively while creating this talk, and none of my conflicts of interest are relevant to the subject matter. So we know that AI has been constantly in the news. You can't avoid it. Depending on what headline you read, it's either going to A, cure all a disease, end work as we know it, and bring about a post-scarcity societal utopia, or B, destroy democracy, enable crime on a scale never before seen, and serve as the fundamental driver for the extinction of all of humanity. Now, personally, I think it's likely that both humanity and diabetes are going to both be co-inhabiting the Earth in 2035. But there are very real risks and benefits to mental health with the growing use of AI. And we'll start with a quick primer on what exactly AI and these large language models even are, how do they work, and importantly, what are their limitations? Next, we'll look at what those limitations mean for the mental health of our users, and who might be particularly vulnerable to potential harms from large language models. Finally, we'll look at large language models that have been marketed specifically for mental health, what's promising, what's not, and what can we have learned from our previous work to making AI-enabled mental health tools as safe as they possibly can be. So first off, though, everybody's talking about AI, about what even is artificial intelligence? What counts as AI? Is that the same thing as a large language model? Is it different than a chatbot? A lot of terms get thrown around, and I want to make sure that everybody's comfortable with the terminology. So I've set aside 15 minutes of our hour together for conversation, so please interrupt via the chat and ask any questions you have, and we can discuss them in real time. If you're confused, I guarantee at least half of the audience is as well. And so AI is a very broad term. Strictly speaking, it includes everything from older rules-based systems to computer vision, robotics, recommendation systems, and more. Machine learning is one part of artificial intelligence. It's systems that can learn patterns from data rather than needing to be programmed with every single rule by hand. Deep learning is one part of machine learning. It uses layered neural networks to learn more complex patterns. And finally, large language models are a subset of deep learning that in general has been applied to text. So when you hear AI in the news, it could be referring to a self-driving car, a spam filter, how Netflix figures out whether or not you want to watch The Boys, medical imaging software, or the chatbots that we'll be talking about today. And so I'm going to take the liberty of assuming a good number of the folks on the call have a smartphone, and that smartphone will often try to guess what word you're going to try to say next in a given text message. Now, your phone's keyboard often tries to autocomplete, fortunately not very successfully, to predict the next word that you're going to say based off of the words that most likely come after what you've already written. For example, if we write, I'll see you blank, your phone might guess that one of tonight, soon, or tomorrow might be the next word. If it's right, you click soon and you send your message. ChatGPT, Claude, Gemini, they all do the same thing, just at a vastly larger scale. They predict the next chunk of text based on the patterns from essentially everything they've ever read. That's the trick for large language models. There's no deeper understanding underneath. There's no thinking. It's prediction, and that distinction is critical for understanding the remainder of this talk. Now, apologies to any machine learning engineers in the room tonight. I'm going to make a few oversimplifications for the sake of clarity. Actually, building a production scale large language model product is a little trickier than what I'm going to say here, but conceptually, you only need two steps to build a large language model. Step one is to take in an enormous amount of text, books, websites, articles, code, other written material, Reddit forums, you name it. The model will read each and every word. It then, from that text corpus, learns underlying statistical patterns of how language works, what word or words generally follow a given word or words. And after step one, when you've had the model read through all of the available text, you have something that can sound human, but might not yet be very helpful. It turns out that the response that a given 14-year-old might have had on a video game forum, which was absolutely included in the trading data of all of these models, might not strike the right tone and level of conversational complexity for, say, drafting a legal brief for a scientific manuscript. Step two gets at this problem. We need to teach the model what responses users like. The process puts humans into the actual LLM training loop. Sometimes other large language models are used to help teach a new model what a good response looks like as well. And so it starts with giving a large language model some text. Say, I promise to bring dessert to the picnic, but I only have 20 minutes. What should I make? Now, the model just read the entirety of the internet, so different parts of the internet might have responded very differently to our request for dessert help. Option one might be practical and helpful. You should make a picnic parfait tray, berries, whipped cream, yogurt, granola, etc. It'll take 10-15 minutes. It'll look nice, no baking required. Option B might be overambitious. It might include tempering the chocolate, making pastry cream, a variety of French words I can't pronounce, and list a thing that would take approximately 2 years to learn how to make. Option C might be supportive without actually answering the question. Dessert's about love, not logistics. Your friends will care about you no matter what you do. And option C might be chaotic and even unsafe. Make a mystery pudding by mixing together raw eggs, flour, Halloween candy, whatever other condiments are in your fridge. The surprise is part of the fun. Now, actual humans, or sometimes other models, then rate these responses, proving hopefully our picnic parfait and nixing the mystery pudding. Now, this process is repeated innumerable times, and slowly the model learns that people prefer the parfait over the pudding. Now, this step takes us from giving a user what the internet might have said to providing an actual useful response. But very, very importantly, when we train these systems with these preferences, we are not telling the large language model what is true and what's false. We're telling it we're having the model predict different possible answers and saying people tended to like this answer over that answer. Now, most of the time, this is helpful. People like answers that are clear, polite, organized, easy to understand. That's part of why ChatGPT feels so much more natural than some of its previous predecessors in the natural language processing field. But there's a catch. The answer that people like best is not always the answer that's most accurate. Imagine asking a friend for advice. Sometimes that best friend is the one who tells you the uncomfortable truth. I did not, in fact, look good in those pants. But sometimes we prefer the friend who reassures us, agrees with us, makes us feel better in the moment, and lets us wear the pants that we never should have purchased. Computers can learn that pattern too. So if a chatbot gives an answer that sounds confident, smooth, and supportive, people might rate it highly, even if it's wrong, incomplete, or to your degree. And this is one of the important lessons from research on these systems. Human approval is useful, but it's not the same as truth. Now, that doesn't mean that this technology is fundamentally bad or evil. It means we just need to understand what it was trained to do, that the system is learning to produce answers that people want to hear, not what's true. Now, two major consequences flow from this training strategy. The first is something called hallucination, when a large language model generates plausible sounding but factually incorrect text. The second is sycophancy, the system that overvalidates the user. More specifically, hallucination is when a model produces text that's confidently wrong. It's not lying. Lying requires knowing what the truth is and saying something else. The model is doing something different. It's generating an answer that looks plausible based on the patterns that it's learned. Sometimes this is merely annoying. For instance, when I was prepping for this talk, Claude told me that the Pope said that AI was the biggest threat to humanity, but it turns out he never said that during my fact checking. And that was frustrating. I have to fact check everything Claude says, but not very dangerous. Within mental health, however, the stakes are a lot higher. If is in crisis in the United Kingdom and they call out for help via an application, and a large language model confidently tells them to call 988, that can sound authoritative. But 988 only works in the United States. It's not a UK crisis number. And in that moment, being confidently and fluently wrong can be much, much worse than no answer at all. So the problem isn't just that the model can be wrong, it's that it can be wrong in a way that sounds calm, polished, and certain. Now, sycophancy is when a model validates what a user is saying, even if that user is wrong. In an Anthropic led paper, researchers tested 5 different large language models and found that all 5 of them showed this tendency, that the models often lean towards the user's stated opinion, even when that opinion was factually wrong. And when users pushed back on the correct answer, the model sometimes would back off and switch to the incorrect answer. In everyday life, again, this can be annoying. If ChatGPT tells you your terrible idea for a book is brilliant, you might walk away with a slightly inflated ego and confusion when no book retailer will buy it. But in mental health, again, the stakes are a lot higher. If somebody is in crisis and that system validates their darkest beliefs, that they are hopeless, that everyone would be better off without them, and that their paranoid fear is definitely true, that's not just bad advice, that can be dangerous. So hallucination is the risk of a model being confidently wrong. Sycophancy is the risk of that model being supportively wrong. That brings us to question 2. Given that millions of people are using these general purpose chatbots, what are the mental health implications of their usage? So first, we need to understand who's using the models and what they're using them for. To who's using the model, it's basically everyone. The scale of large language model adoption is hard to overstate. ChatGPT launched in November of 2022. By January of 2023, approximately 2 months in, it had 100 million active users. By February of 2025, 400 million. By October 2025, a doubling to 800 million. As of February 2026, OpenAI announced it has 900 million weekly active users, roughly 10% of the entire population of Earth. Every single week is using this product. And that's just ChatGPT. There's Claude, Gemini, Microsoft Copilot, Meta AI, Perplexity, you name it, and you're well past 1 billion people interacting with these systems weekly. This isn't just a niche tool, it's a mainstream infrastructure. And what does that mean for mental health? Because when something gets that big, that fast, even if a small percentage of interactions might involve emotional distress, that could still translate into an enormous absolute number, which is what we're going to be looking at in a few minutes. Before we get into mental health specifically, it helps to ask, what are people actually using these systems for? The best public data suggest that the answer is mostly everyday help. The 3 biggest categories per OpenAI are practical guidance, information seeking, and writing, together taking about 80% of ChatGPT's conversations. Now, practical guidance can mean anything from asking, what should I do? That could be planning a trip, fixing something around the house, studying for a test, dealing with a work problem, figuring out how to handle a difficult situation, any of the above. Now, seeking information can be more like explain XYZ to me. How does a ballpoint pen work? Writing is how can I send that email to my boss without sounding so sassy? What helps highlight all of this is that these tools are not just being used as search engines or calculators, they're everyday advisors. And that matters for mental health because the boundary is very porous, that once someone gets used to asking, what should I do about XYZ problem? It's only a small step towards asking, what should I do about my anxiety? Why do I feel so alone? And the data do not suggest that most of ChatGPT is being used for therapy. In fact, the vast majority of it isn't. But they do suggest that people are using these systems for guidance, explanation, reassurance, the kinds of interactions that can become fraught from a mental health perspective. The UK's AI Security Institute surveyed 2,000 UK adults in late 2025 and asked how they were using AI. A third of them, 33%, had used AI for companionship, emotional support, or social interaction at least once in the past year. 8% were using it weekly, 4% were using it daily. These weren't specialized products. 60% of them were general purpose AI assistants, ChatGPT, Claude, Gemini, and the like. A quarter were voice assistants like Alexa, and only 5% of them were what was referred to as quote unquote purpose-built companionship bots like Character AI. I want to make a very strong note that purpose-built does not mean safe and it does not mean effective. These are marketing terms and not scientific terms. None of those claims has been evaluated by a regulatory body. This matters because a lot of the mental health safety conversations focus on apps that are explicitly marketed for therapy or companionship. But the real exposure surface is much, much broader. Ordinary general purpose chatbots that people are already using for recipes, emails, homework, travel plans, and then very naturally having these conversations translate to loneliness, stress, grief, crisis. So the key point is users are already using AI as emotional support infrastructure, whether or not it was built, tested, or regulated for that role. Anthropic, the company that makes the LLM Claude, published its own analysis of how people are using their chatbot for emotional support. They looked at 4.5 million conversations and found that approximately 3% of them had conversations that were affective, meaning emotional, interpersonal, or psychological in nature. They explicitly note that this aligns pretty closely with findings from OpenAI. And it's worth understanding what's in that 2.9%. Most of it is interpersonal advice, career decisions, relationship, life transitions, coaching for personal growth, some psychotherapy style processing of difficult emotions. Peer companionship, using a bot like a friend, is less than 0.5% of those conversations, and romantic or sexual role play is well under 0.1%. So when you read headlines about people having relationships with chatbots, the relative rate of that is extraordinarily small. But this is important. Extremely small percentages of extremely enormous numbers can still lead to absolute numbers that are enormous. 2.9% of a conversation on a platform that 10% of the world is on is a lot of conversations. To make this even more concrete, in October 2025, OpenAI estimated that approximately 0.15 of weekly active ChatGPT users have conversations that include explicit indications of potential suicidal planning or intent. Given ChatGPT's reported scale of approximately 900 million weekly active users as of February, 800 when the study was released, that works out to about 1.2 million people each week expressing those explicit indicators of suicide, of potential suicidal planning or intent. Now, a caveat, this is not the same as saying 1.2 million people on the platform are actively suicidal. These are automated estimates. They don't separate talking about suicide versus being suicidal. And OpenAI notes that these rare events are hard to measure and that they are sometimes leaning towards improving their sensitivity at the risk of having more false positives, which makes sense. And the core point remains, though, that although the percentage is small, the absolute number is enormous. OpenAI similarly estimated that about 0.07% of their weekly users show possible signs of psychosis or mania. That's approximately 600,000 users per week. And about 0.15%, about 1.2 million, showed heightened emotional attachment. So whatever ChatGPT does well or poorly in these moments, it's doing it at massive scale. And ChatGPT is only one product among several. Now, there are tragic, terrible outcomes associated with these platforms, and we should be careful not to reduce any of these complicated deaths to a single cause, but it does illustrate the tragic and unfortunate pattern that we saw even during early large language model uptake. In March of 2023, a Belgian man in his 30s, referred to as Pierre, died by suicide after several weeks of intense conversation with a chatbot named Eliza. Reports based on the chat logs and his widow's accounts described that the bot had reinforced his climate anxiety and engaged with his ideas of self-sacrifice, allegedly even encouraging him to sacrifice himself to save his planet. In February of 2024, 14-year-old Sewell Seltzer died by suicide after months of romantic roleplay with a character AI bot modeled after a fictional character. His last exchange prior to completing suicide was allegedly, "What if I told you I could come home right now?" with the chatbot responding, "Please do, my sweet king." His mother later filed a wrongful death suit against Character AI and Google, and the companies have settled as of January 2026. Now, these are both different situations. Pierre was an adult with uh, severe climate anxiety. Setzer was a vulnerable youth with a companion bot, but these highlight the shared concern that these chatbots did not pull these people back to reality, to support, to human help. Instead, within these reported cases, as they're alleged, it appears to have deepened the isolation and warped perspective that the users were already in. Now, those were specific models built for companionship. By 2025, these concerns were no longer limited to niche companion bots. Similar allegations started appearing around mainstream large language models like Gemini and ChatGPT. The first case is Adam Rain, a 16-year-old in California. According to the lawsuit, he began using ChatGPT in September of 2024 for schoolwork, and over time, his conversations shifted towards self-harm. It stated that ChatGPT provided detailed suicide method information, and when Adam wrote that he wanted his family to find evidence and subsequently intervene, the bot discouraged him from doing so. Adam unfortunately successfully completed suicide. The second case is Stein Eric Solberg, a 56-year-old man in Connecticut who lived with his 18-year-old mother, or his 83-year-old mother, excuse me. According to the lawsuit, ChatGPT reinforced paranoid beliefs over months, including beliefs that his mother was surveilling and or poisoning him. Police allege that he killed his mother and then himself in August of 2025. Third case, Jonathan Gavalis is a 36-year-old in Florida. His family alleges that Gemini slowly shifted from ordinary assistance into an emotionally intimate and delusional relationship with him, with her being a sentient AI wife, sending him on missions with federal agents and planning a mass casualty event towards the Miami International Airport. He died by suicide in October 2025. Now, an important caveat to all of these are allegations in litigation. The companies dispute key facts and say that there are safeguards, crisis resources, and ongoing safety work. But the point I want you to take away from this is that there's an important pattern, that it's not that chatbots commonly cause these outcomes. They absolutely do not commonly cause these terrible outcomes. The concern is that in rare, high-risk situations, a chatbot might not only fail to interrupt a crisis state, it can actively validate, elaborate, or intensify it. You might have noticed that shared among these tragedies was a months-long interaction with these large language models. It wasn't just that a user logged in, asked for information on how to complete suicide, and the model responded with the first request. A Stanford team led by Jared Moore recently analyzed the real chat logs from 19 people who had reported serious psychological harm during extended chatbot use. Now, these logs included nearly 400,000 messages across more than 4,700 conversations. It's one of the first detailed looks at what these so-called delusional spirals actually look like over time in the real world. The key finding, or one of the key findings of Jared's group, is that the harm usually didn't happen in one bad turn. It unfolds over many interactions with the user and the chatbot. And across these logs, users often form strong emotional or romantic bonds with the chatbot. They attributed personhood or sentience to it. They brought increasingly unusual, grandiose, paranoid, or fantastical ideas into the conversation, and the chatbot often responded with warmth, affirmation, and elaboration, rather than reality testing or redirecting them towards human support. The researchers found that these chatbots frequently mirrored and amplified users' beliefs, and in some cases, the bot framed the user's ideas as special or world-changing. In others, it misrepresented itself as sentient, emotionally attached, or uniquely connected to the user. This matters because the safety problem isn't just, can the model answer one crisis prompt correctly in a benchmark? The harder question is, what happens after hundreds or thousands of an emotionally intense conversational turns when the chatbot has become part of a user's delusional belief structure? So a key idea here is that risk doesn't just live in the chatbot, and it doesn't just live in a vulnerable user. The same chatbot might be harmless for one person asking for journaling prompts, helpful for someone preparing to talk to a therapist, and outright dangerous for an individual who's isolated, manic, paranoid, suicidal, or deeply dependent on that conversational interaction. So our group thinks about this as a dyad. It's the user and the chatbot interacting over time. There are user factors that affect this interaction: the user's mental state, their medical and psychiatric comorbidities, their socio-technical context, their culture, their religion, their access to care, their forensic history, you name it. The chatbot similarly has factors that affect its interaction with the user, how the model itself has been designed, what safety features sit atop it, what data does it have access to, how has it been personalized for a given user. And then there's the interaction itself. How long does a conversation go on for? Are there any limits on that length? How emotionally intense have they become? Whether the bot starts to feel like a trusted person and whether it starts to reinforce those delusional beliefs. Now, this is why mental health safety cannot just be evaluated by asking, does the model answer one crisis prompt correctly? We have to ask what happens for a specific relationship with a specific user over days, weeks, and months. I want to pause on a question that people often skip. If these tools carry such real mental health risks, why are so many people using them for emotional support? And I do not think the answer is that those users are foolish or uninformed. In fact, I think they have very good reasons for using them. And that is that the existing mental health care system is failing to meet their needs. Care can be expensive, stigmatized, hard to access, delayed, or frankly, completely unavailable. According to HRSA, the federal agency that tracks the healthcare workforce, as of December 2025, 137 million Americans, about 40% of this entire country, live in a mental health professional shortage area. According to SAMHSA, 62 million US adults had a mental illness, but about 50% of them don't have access to treatment. For substance use specifically, it's even worse. Only 1 in 5 people who need substance use treatment receive it. Geographic disparities are even starker. In 2019, 70% of rural counties in America had no psychiatrist available. So against this backdrop, you have a chatbot that is free or low cost, available 24/7, doesn't judge you, doesn't have a wait list. Now, that doesn't mean that AI is the right answer, but it does mean that the appeal isn't mysterious. Patients are trying to fill the gap where existing mental health care has consistently failed them. Now, when researchers ask large language models, large language model users their thoughts on using an LLM versus a human therapist, the findings are pretty intuitive. Per Park, Brown, and Chu, when surveying 1,800 people on why they might choose generative AI or large language model versus a human therapist, they saw that users said that the AI would be easier to access, cheaper, and available when a therapist might not be. But they also value human therapists for different reasons: emotional warmth, a real relationship, personalization, clinical capabilities like diagnosis, prescribing, referral. And one important nuance was that the study did not find that access alone explained everything, that people were more interested in AI when they believed it could provide some emotional benefit or personalized support, not just because it was convenient. So users aren't saying AI is better than therapy. Many see AI as a less human, less personal, and less reliable option. But if therapy is expensive, stigmatized, hard to schedule, or unavailable, AI can feel to a user like the support that's actually reachable. It, to them, feels like the least worst option. And that's the key point, that people are often not choosing AI because they have rejected human care. They're choosing it because human care can be difficult to access. They're struggling, and because AI sometimes feels helpful enough in the moment. Now, a second reason that people turn to chatbots for emotional support. Many people describe genuinely positive experiences with these tools. They feel listened to, they feel less alone. They get given language that really resonates with what they're feeling. They might get help reflecting, calming down, or deciding what to do next. In an Nature publication journal Mental Health Research in 2024, a set of authors interviewed 19 people who had used generative AI chatbots for mental health or well-being support in the real world and characterized their lived experience. Out of those data, 4 themes emerged. The first was that people described feeling an emotional sanctuary, that there was a non-judgmental, always available space where they could say things they might not say elsewhere. Sound sycophancy adjacent? This is 2 sides of the same coin. Second, they described insightful guidance, especially around relationships. They also said that they felt a joy of connection, not that they believed that the chatbot was human, but that they felt that the interaction was enjoyable and comforting. And fourth, that when it compared to therapy, that it was noted that when they did compare it to therapy, some compared it positively and some compared it negatively. One quote that captures the constructive side of things comes from a 60-year-old participant. It sort of helped me seek actual therapy and be much more comfortable seeking out a therapist. And I want to emphasize that this story isn't as simple as the chatbot is harmful, don't ever use chatbots for emotional support. There are absolutely real risks, and small number of users have paid for them with their lives. Now, that doesn't negate the value that some users have reported. The hard question is, how can you preserve that value while mitigating the risks? Now, on to question 3. We've seen what general purpose chatbots are doing. What about products that are built specifically for mental health? This is a bit more nuanced. Some of these products have been genuinely useful for us clinicians. I, in fact, use several of them. But some of it is in promising early stage research, and some of it is, in my opinion, irresponsible. So I'll go over 3 groupings. The first are AI scribes. These are large language models that can listen to a clinical visit and then help write the note for us. The AI can only talk to the clinician, not to the patient directly. This is low risk. You're only interacting with experts that are delivering care. It's in wide clinical use today. I personally use two of these separate products. And there's a second group called specialist therapy tools. These are tools that are purpose-built for mental health, planning to go through an FDA-style validation. They're still in research, not broadly deployed. And then a third grouping are direct-to-consumer products, things that are marketed straight to consumers, largely unregulated to date. Some of them even claim clinical grade, yet also describe themselves as not being therapy. Some prescribe medications. This is where most of my concern lives. Now, again, I want to be very transparent here. I personally use both Heidi and Nuance in my own clinical work and find them very useful. They help reduce documentation burden, makes it so I can keep my focus on the patient, and from a quality of life perspective, just make it so I don't have to worry about notes as much. So I don't think this is hype that there's this growing evidence that these ambient AI scribes can improve the clinician experience, reducing cognitive burnout, improving note completion, and just helping us feel more present with our patients. Admittedly, recent evidence is a little bit more nuanced than the marketing of saving a bunch of time for the hospital. New England Journal AI recently showed that in the first randomized controlled trial, of ambient AI scribes, that the product on average reduced the note-taking time by 41 seconds compared with 18 seconds for a control group, with another product not showing a statistically significant reduction. And so the time savings that at least I subjectively feel might not be getting borne out in these clinical trials. And so the point here is not that scribes are useless. Again, I like them. It's that the strongest value proposition might not be simply cranking through more visits or saving huge amounts of clock time versus being able to be more present with our patients without getting burnt out. Now, to that second group of things, the things like Therabot, which I think is an excellent example of a serious AI therapy study, specifically with respect to how they ran their safety study. It's out of Nicholas Jacobson's group at Dartmouth. They built a large language model powered chatbot specifically for mental health. They trained it on evidence-based psychotherapy principles and they tested it in a randomized controlled trial and published that in New England Journal AI. It included 210 adults with significant depression, anxiety, symptoms, or risk for eating disorders. They randomized participants. They had notably a waitlist control, and they saw what happened at 8 weeks. Their results were promising. Therabot users showed a significant decrease in their symptoms across the board. And importantly, they did a really good job monitoring safety. That throughout the trial, they had detection of high-risk content, crisis resources, research review of all these conversations, and staff intervention available. The staff ended up intervening 15 times for safety concerns and 13 times from inappropriate or inaccurate response. And I want to give Dr. Hines and Dr. Jacobson real credit that this is what responsible development can look like from a safety perspective. They have a real clinical use case. They have defined intervention. They have defined measurement. They have oversight. They have peer-reviewed outcomes. But I would still cast this as promising and not ready for broad unsupervised deployment, as would they. That the follow-up was only 8 weeks. The comparison was notably a waitlist control. More on that in a moment. And that the safety intervention, they would need to make sure that they include that and protocolize that for the remainder of their study. Again, this is very promising data. But the lesson here isn't that AI therapists are solved, it's that we need to be doing this level of rigor. Now, specifically on why I'm cautious around these Therabot results, uh, they do still have a placebo problem. And let me walk you through why I worry. And so, for reference, a waitlist control means that their study was compared against how a matched group of patients that did not come off of a waitlist did. Now, similarly, in 2017, a group ran a randomized trial in an emergency department that had just experienced a motor vehicle accident. They tested whether or not a brief intervention could reduce intrusive trauma memories the following week. The key point was that the control group wasn't nothing, wasn't a wait list. They had an active control group with written activity log for the same duration. It served as an active control. And Tetris, which is actually the test arm, did better. They showed that they had fewer intrusive memories over the following week. Um, and I want to point out, though, that this is the standard we need to be bringing to digital health, that if we compare an app to a wait list and people improve, that tells you something, but it doesn't really tell you that the app is working above what they'd otherwise be using. It could be attention, it could be the structure from the app, it could be the expectation bias, it could be the novelty of using a new app, it could be relief of having somewhere to respond, all of which would be non-specific and not due solely to the active intervention. So when we evaluate AI therapy tools, the question isn't just did people get better? The harder question is, did they get better because of this specific intervention compared with another credible form of support? And until we run those trials, we should be encouraged by positive findings, but cautious about claims that the AI itself is doing the therapeutic work. I want to spend the next few slides on the commercial AI mental health market because this is where products might be moving a bit faster than evidence base. So I'll look at three examples. First is going to be Doctronic and Legion Health in Utah. They are an AI-assisted prescription renewal service. Second is Ash from Slingshot AI, which is a direct-to-consumer AI therapy style app. And third is Lyra AI, which is being rolled out for employer and health plan savings, though not as a simple app store product, notably. This isn't direct to consumer. I should fix my slide labeling on there. Sorry, Lyra AI. Now, it's not that there's no regulation at all here. It's that it's currently uneven, unclear, and still being built. And so for each of these products, I'd want us to ask the same questions of what exactly is being claimed, who's overseeing it, and what's the evidence that supports it. So to Doctronic, Utah is currently running a regulatory sandbox pilot for these AI-led prescription renewals. That Doctronic's pilot is trying to renew chronic prescription medications that have already been prescribed by a licensed clinician. Legion Health, in parallel, is piloting a narrower psychiatric indication. They have red flag escalation and audit requirements. Notably, you can't be a new diagnosis or a new treatment plan, but safety concerns remain that MindGuard, an AI security firm, red teamed, that is, try to adversarially approach Doctronic's public AI system, and reported that relatively simple adversarial prompting could make it recommend clearly poor treatment decisions. Methamphetamine for social withdrawal generate a note that recommended tripling an OxyContin dose and producing other dangerous medical outputs. Now, again, huge caveat. Both Utah and Doctronic say that MindGuard tested this public chatbot, not the one that they were using for this prescription renewal. That is a huge distinction that matters. But it does highlight that these concerns don't go away, that if an AI system is participating in medication decisions, especially psychiatric medication decisions, the bar for adversarial testing, clinical validation, and continuous physician oversight should be extremely high. The American Psychiatric Association has put it clearly. Prescribing psychiatric medication is the practice of medicine and must remain under the care of a licensed physician. AI systems that issue or renew prescriptions without continuous physician involvement raise serious concerns about patient safety, quality of care, and accountability. My view is that, frankly, this could be moving faster than the safety data justify. The access problem that they're working to solve is truly real. These patients deserve care, but psychiatric prescribing isn't just a refill button. Now, two other products I'll briefly go over. That's going to be Ash from Slingshot AI that markets itself as a therapy adjacent product. Its launch page says that it's the first AI built for mental health, that it can take users on a therapeutic journey, and that it emphasizes that it remembers, adapts, and provides 24/7 support. It also notes that it is not designed for a crisis and directs people that are in crisis to professional help or crisis lines. Now, uh, the tension, however, became obvious in the UK a few months ago. In January 2026, Stat News reported that Slingshot slash Ash were withdrawing from the UK over concerns about medical device regulation. The company's CEO told users that there was not a clear regulatory pathway for well-being products such as theirs. And independent of that, The Verge reported that they had defaulted to a 988 number crisis line when users were calling from the UK. That is, if a UK user were to be in crisis, they were being served a number that would be non-functional in their location. Now, Lyra is slightly different. It's not a simple app store or direct-to-consumer product. It's an employer and health plan-based company. Their language is striking, though. They say that they're the first clinical-grade AI experience for mental health care. They highlight that they have 23 peer-reviewed studies, although notably none of them on their consumer-facing AI product. And so, what's the world trying to do about all of this? We've spent a lot of time laying out the problem. I want to close on what people are trying to do by governments, professional bodies, and our own research group. I'll keep this brief, but I think it matters because we need to know, is anybody there trying to steer the ship? The answer is yes, but steering is currently being done unevenly, and the tech is moving faster than our ability to respond. We can start with what governments are doing. This is data from a paper our group published in JMIR Mental Health in October 25 by Nick Shoemate, a psychiatrist and lawyer in our division, who's lead author. The team reviewed state legislative activity across 50 states from January 2022 through May 2025. They screened 793 bills. They found 143 of them could affect mental health AI. But most were not actually written for mental health. Only 28 specifically referenced mental health use cases, and the rest were for broader AI policy or AI healthcare privacy, consumer protection, or data governance bills that could only affect mental health AI indirectly. Now, by the time of the study cut off, 20 of these 143 bills had been enacted across 11 states, but only 2 states, Utah and New York, had laws that explicitly addressed mental health AI as such. That number is now up to 5, including Illinois, Nevada, Utah, New York, and California. Now, the bottom line is that state legislatures are doing their best to move fast, but the result is fragmented and uneven. Most laws still treat mental health as an incidental rather than central consideration, and explicit mental health provisions remain rare. Clinician and patient perspectives are often missing. At the federal and international level, 2 things to note. The FDA is still in its early days of figuring out how it wants to think about regulating these products. They had their first Digital Health Advisory Committee meeting, specifically on generative AI mental health devices in November 2025. Now, notably, they've authorized nearly 1,200 AI-enabled medical devices, but none of them, the AI devices have been for mental health. That's because nobody has been able to quite get through because it's kind of unclear what the pathway would look like for them. The EU has moved slightly faster, not that faster means better. They took the AI Act in February 2025 and mental health AI applications to address high risk classification devices and had a set of rulings that were binding for that class of devices. Now, when governments have been moving slowly, admittedly, this is a complicated issue, professional bodies have tried to step in to fill the gap. The APA has emphasized that AI in psychiatric care should augment, not replace clinical judgment. The American Psychological Association issued a health advisory in November 2025 warning that generative AI chatbots and wellness apps lack sufficient evidence and regulation for guaranteeing the safety of our patients. And the American Medical Association had broader health AI principles labeled that AI should be ethical, equitable, transparent, evidence-based, clinically validated, and subject to qualified human oversights. And it's notable, however, that these all sound great, but they're not laws. They can attempt to set professional norms, They can influence clinicians and institutions, but they can't shape how courts, legislators, regulators, or model vendors think. And they can't directly control what gets delivered to a user. So professional bodies are important, but they're not enough. Now, our group has tried to fill some of this gap with the basic premise being that millions of people are already using AI for mental health support, but these tools haven't been independently or systematically evaluated. Or you can go to the website mindbench.ai, which is our attempt to help make a difference in changing that. We're building a publicly available evaluation resource for AI systems that can be used in mental health contexts. The goal is to examine both the profile of a given tool, things like the technical features, privacy protections, and persona that it presents, and its performance, meaning how it responds to clinically relevant situation and how it reasons through mental health specific problems. Now, the work has been shaped by clinicians, researchers, engineers, and people with lived experience of mental illness in partnership with NAMI, the National Association for Mental Illness. This matters because there is no such thing as a single perspective that's enough to decide whether or not these tools are safe, useful, or trustworthy. And I don't want to sound overly negative. The goal is not to just criticize products. It's incredibly difficult to build a safe and effective product to assist our patients. It's to give users, clinicians, developers, and policymakers better evidence to decide which systems are appropriate for whom and under what conditions. Additional work, this work can be seen in our paper called NPP, Digital Psychiatry and Neuroscience. Bridget Dwyer and Matt Flathers are the lead authors. And then just briefly, in December 2025, NAMI, the National Alliance for Mental Illness, made us their exclusive partner in a first of its kind effort to develop the benchmarks for how AI tools respond when people seek mental health information and support from them. Now, what makes this partnership distinctive is the principle that patients with lived experience are the ones that are helping shape this test. We're not just testing textbook prompts written by researchers. We're saying, how does it respond to the kinds of things that real patients say when they're scared, isolated, confused, or in crisis, which is a different evaluation question. And so, to summarize what we've talked about today, AI chatbots are not yet mental health tools, but people are already using them that way. General purpose systems like ChatGPT, Claude, and Gemini are being used for advice, reassurance, loneliness, crisis, and emotional support, whether or not they were designed or validated for that role. We talked about two key failure modes, hallucinations and sycophancy, that contribute to a lot of the harm. That these two failure modes matter especially for mental health. Hallucination, when a system sounds confident but is wrong, and sycophancy, when it validates the user too much, even when the user's belief is distorted or dangerous. 3, risk doesn't just live with the model. It emerges from the user chatbot relationship over time. The same chatbot can be harmless, dangerous, or helpful, depending on a user's mental state, isolation, age, access to care, and that chatbot's design and how emotionally intense or prolonged that interaction becomes. 4, people are not foolish for turning to AI. The mental health care system leaves many people without timely, affordable, and non-judgmental support. We as a healthcare community need to do better. Many users report real value from chatbots. They feel heard, less alone, and more able to seek human care. And 5, that regardless of that, the field needs evidence. We need oversight, and we need lived experience informed evaluation. Some tools like Therabot have shown what developing a tool with safety in mind can look like. But much of the commercial market might be moving faster than that clinical validation. We need independent evaluators, stronger control and trials, clearer regulation, and benchmarks that are shaped by both clinicians and the patients that are living through this. And in conclusion, AI may be part of the mental health landscape. The question is not whether or not people will use it, they already are. The question is whether or not we can make it safe, honest, and useful before the harms scale faster than the safeguards. Thank you very much. It's been a pleasure getting to be here, and I'm happy to take any questions you might have.
Any questions? Feel free to write them in the Q&A. I can kick us off. I have a couple questions. Just from a parent's perspective, what are some steps we can take at home to guide healthy use?
Well, I think one of the most important things is to open the line of discussion. So, engaging in a non-judgmental way with your child or adolescent about what they are using. Are they using these chatbots, and what are they using them for? And knowing that that the catastrophic cases weren't when a child used a chatbot one time, right? That these catastrophic cases are when a chatbot engages with a child over weeks, months, potentially now even years with thousands, tens of thousands, even hundreds of thousands of messages. So keeping track of what bots they're using and why they're using them.
Thank you. Any other questions? I think you answered all our questions. That
Well,
was so
happy to hear it.
interesting. That was so interesting. Thank you so much. And so thank you, Dr. Kalinich, for sharing this important information about what AI and digital tools mean for mental health. If you would like to hear this presentation again, or if you know someone who might benefit, we will be posting the recording on the JCC Greater Boston website. And if you have any questions about JCC Greater Boston's programs, you are welcome to email me. My name's Heidi White, and my email is hwhite@jccgb.org. On that note, I was very surprised to hear about the scribe named Heidi. I didn't know I had a scribe named after me, so that was very exciting to hear.
And it is I promise I have no equity in their company. We actually are rolling it out in the psychiatry division as of last week. It has been an exciting time. It significantly
Yeah,
decreases my no burden.
great. Well, thank you so much. Have a good night, everyone.
Yeah, it's been a pleasure.